everyone to the hands-on workshop at Chulalongkorn Minimally Invasive Surgery. Today is the second day of the course. Yesterday we do the Endo-Lap management of the gastric submucosal lesion at the T-TEC, and we have a lot of fruitful today we move to Chulalongkorn minimally invasive surgery to do the common upper GI disease, and we have many speakers for today. The first one, I would like to invite Dr. Professor Suthep Udomsawaengsup. He is the Director of Advanced Laparoscopic and Bariatric Surgery in Chula Minimally Invasive Surgery to have the welcome speech to everyone.
Dear Professor Michael Lee, the Chairman of APELS, colleagues and friends. First, I would like to again thank you, Professor Lee and the APELS for allowing us to hold the APELS Localized Hybrid Module. And I hope all of you will be enjoying the lectures and workshop yesterday, which are very fruitful and very packed with the experiences at T-TEC Thailand. Thank you very much. And today we'll continue for the second part, which is going to be focusing on the Endo-Lap management of common benign upper GI diseases. And today in the morning we have our national expert in upper GI diseases as well as friends here. And in the afternoon we will have the hands-on workshop in our cadaver at King Chulalongkorn Memorial Hospital. I wish all of you enjoy the program that we've been preparing. And also I would like to thank the course director and also the scientific chairman who are sitting here, Dr. Kanokkan Tepmalai, and also Dr. Bandhuphat. I would also like to thank all support and contribution from the national and international speakers. Thank you.
Thank you, Professor Suthep. So good morning again, our audience here in this auditorium and also in Zoom. Today, first lecture, we're going to start with the overview in Achalasia about the diagnosis and workup. We would like to introduce Dr. Pornthep a little bit. He's the surgeon's advanced lab, Endo-Lap at Thaksin Hospital, Bangkok, Thailand. He graduated from, have fellowship in American College of Surgeons. He also a member of many organizations, ASGE, SAGES, THS, Morbid Obesity of Thailand, and he also a committee of Lab Endo-Surgeon Society of Thailand too. So please welcome Dr. Pornthep, Prathanvanich, please.
Thank you. Thank you, Chairman and Co-Chairman. Thank you, Professor Suthep, all organizing committee in APELS. So today I'm going to talk about overview in achalasia, diagnosis and workup. So achalasia means non-relaxation, usually present between age 25 to 60, equal in both gender, male and female, mostly happen in Caucasian. So the average symptom duration at diagnosis is about 2 to 5 years. So this is a pathophysiology of the achalasia. This is esophagus. You can see the patient loss of gangrenic cell in myenteric plexus, distal to proximal, that make the patient cannot swallow well, like with the dysphagia symptom. And also some patients have vagal fiber degeneration. And up to 50% of patients has antibody to myenteric neuron. Most of the clinical presentation is the dysphagia, more than 90%, regurgitation, cough, aspiration, chest pain, heartburn, and also significant weight loss. This clinical scoring system of achalasia is called Eckhart score. The score is 0 to 12. So you have to know how much the weight loss of the patient and how's the severity of the dysphagia, retrosternal pain, and regurgitation, and can stay to from 0 to 3 stage. So this is all the investigation from basic to advanced investigation of achalasia. You can see from the plain film, you can see widening of mediastinum due to dilated esophagus, and also absence of gastric air bubble due to failure of lower esophageal sphincter relaxation. And balanced swallow, you can see dilatation of esophageal body or sigmoid megaesophagus. And also the typical is a Bird-beak sign like this, is smooth tapering of EG junction. It depends on what state you face with the patient. Like picture A, you can see the early achalasia. If the patient untreated for 2 years, the esophagus will dilate like that. And at the end, instead of achalasia with megaesophagus, you can see at the picture C. So these are all the investigation of dysphagia. So you have to separate oropharyngeal dysphagia. So this symptom of esophageal dysphagia, you can start with upper endoscopy. For oropharyngeal dysphagia, you can start with upper GI study. So from upper endoscopy, you can find maybe obstructive disease like a benign stricture or cancer at cardia. If you found everything normal or esophageal dilatation, retained food, something like that, you can continue investigation with high-resolution manometry. This example for achalasia and pseudo-achalasia. You have to be careful, especially for the elderly patient with the short course of the symptom of dysphagia. So for typical endoscopic finding, you're going to find with the very tight cardia, but without any mass or lesion. And you can find retained food like this or megaesophagus. So how about the high-resolution manometry? So these conventional esophageal manometry that when I was MAS fellow like 15 years ago, we used that. You can see when the patient swallow, this peristalsis of the esophagus, and this lower esophageal relaxation time when the patient wet swallow. Normally, the upper esophageal sphincter, normal pressure is about 60 mmHg, and lower esophageal sphincter about 10 to 20. When the patient swallow the water, the pressure down to 15 at upper and esophageal sphincter and 0 at lower esophageal sphincter. So this conventional manometry show typical of achalasia. You can see when the patient swallow water, no peristalsis at all, and impair lower esophageal sphincter relaxation. The pressure not down to 0. So we can diagnose achalasia. So this esophageal high-resolution manometry. It makes esophageal physiology easy to interpret, practical advantage, easy to learn, simple, cheap, and time-effective, and also improve diagnosis accuracy. Also, it can classify subtype of achalasia to type 1, 2, and 3, that we can predict the treatment response based on the subtype. As you know, type 2 is the best, and type 3 is the worst outcome. This normal high resolution of the manometry. You can see upper esophageal sphincter. When swallowed, this proximal esophagus transition zone is here, and this distal esophagus, and this crural diaphragm. So this relaxation of lower esophageal sphincter, like this again. So this picture compare conventional and high-resolution manometry. You can see high-resolution manometry can show all anatomy and the pressure. This is a real picture in the computer. So computer gonna analyze all the pressure for you. So how to read high-resolution manometry? First, the study begins with the evaluation of the resting pressure, the high pressure at upper and lower esophageal sphincter like this. So when you put the catheter in, don't need to pull back, and you can find the high pressure here is upper and esophageal sphincter, the red one, and there's a lower esophageal sphincter, the green one, and the blue one is intrathoracic pressure is almost 0. And you have to know the pressure inversion point. This is the point where the negative pressure generated by intrathoracic pressure change to positive pressure generated by intragastric pressure. So again, you can find upper esophageal sphincter, intrathoracic pressure, and this line is different from intrathoracic and intragastric. This is a lower esophageal sphincter. And then define whether lower esophageal relaxation is normal or not when the patient swallow. So we're going to know IRP is an integrated relaxation pressure. So this normal high-resolution manometry, again, you can see upper and lower esophageal sphincter. Then the patient swallow this peristalsis. And you can see lower esophageal sphincter relaxation time is here. Normally, IRP is less than 15 mmHg. This normal high-resolution manometry. So again, find the upper and lower esophageal sphincter. Let the patient swallow, see the peristalsis of the esophagus and lower esophageal relaxation. And how about this? Again, find upper and lower esophageal sphincter. Let the patient swallow. You can see upper esophageal sphincter relaxation here, but no peristalsis at all. And IRP is still high, more than 15. That means the patient have EGJ outflow obstruction without peristalsis. That means we can confirm that is achalasia. So IRP more than 15 mmHg mean increased resistance to bolus transit in EG junction, and this is pathological. So the cause it may be functional or mechanical, but you have to rule out CA cardia, stricture with the endoscopy before. So this Chicago classification. So classify to EGJ outflow obstruction with the IRP high, more than 15, and this IRP less than 15, this normal EGJ relaxation. So when you found that the patient has IRP abnormal, more than 15, then you try to find peristalsis. If the patient absent peristalsis, is confirmed achalasia. If the patient has some weak or intact peristalsis, it's called EGJ outflow obstruction. That can be achalasia variant, mechanical obstruction, or hiatal hernia, or post-Nissen fundoplication. Like this, again, upper and lower esophageal sphincter, wet swallow, and you can see no relaxation at all. But then the patient still have some peristalsis. So this is not achalasia. So this distal esophageal stenosis. Again, upper and lower esophageal sphincter, wet swallow, no relaxation. So it's go to EGJ outflow obstruction. Next, see the peristalsis. The patient have some peristalsis. So this is EGJ outflow obstruction, is not achalasia. So this patient underwent Nissen fundoplication. So for the normal EGJ relaxation, IRP less than 15 mmHg, it can be distal esophageal spasm, hypercontractile disorder, something like that. So these are the type 1, 2, and 3 of the achalasia. Type 1 without pressurization. Type 2 with the, you can see the pressure in the esophageal body more than 20%. And type 3 with the distal esophageal spasm. So start with the IRP more than 15 mmHg with no peristalsis, confirmed achalasia. Type 1, no lower esophageal relaxation without peristalsis. Again, this type 1. Type 2, no relaxation of lower esophageal sphincter, but the patient has pan-esophageal pressurization to a level above 30 mmHg, so it's turned green other than blue. This type 2. About the type 3, you have to know the term of distal latency. So follow me about what is the CDP and DL, distal latency. So CDP is the point at which the speed of the waveform decreases. So it's this line and go to this line. So this is a CDP point. And distal latency is obtained from the interval time between start upper esophageal sphincter relaxation here to CDP. So mostly more than 4.5 seconds, this normal. Like this normal. This CDP is here, this distal latency. For type 3, it's happened because it's like a premature contraction of distal esophagus. So the distal latency is less than 4.5. So high IRP, high spasm at distal part of the esophagus, and distal latency less than 4.5. We can confirm with the type 3 achalasia. So this normal swallow, type 1, type 2, and type 3. Again, this compared with the balanced swallow, you can see type 1 is dilated of the esophagus with the non-relaxation of lower esophageal sphincter. Type 2, the esophagus is not dilated much. Type 3 is like a spasm. So why we have to classify achalasia to type 1, 2, 3? Because you're going to learn more about how to treat that. Type 1 can treat with any modality. Type 2, we prefer pneumatic dilation. Type 3 is POEM. You're going to learn more in the next section. So this is all the guideline to treat achalasia, including endoscopic treatment like a Botox injection, pneumatic dilatation, or POEM, or surgical treatment that you're going to learn in this afternoon with the hand-on workshop. So this pre-op balanced swallow, and this post-op after laparoscopic myotomy. So proposed model of achalasia phenotype start with the viral infection or immunogenetic background with myenteric plexus inflammation. So this arm with the cytotoxic immune response, progressive loss of myenteric neuron, and start with EGJ outflow obstruction and turn to type 2 first and then type 1 and end state like this. So start with the EGJ outflow obstruction. Right? You can see high IRP, but still some peristalsis. And then turn to type 2 with the pan-esophageal pressurization, and then turn to type 1. for this arm with a non-cytotoxic immune with EGJ outflow obstruction and turn to type 3 achalasia. So this is the last one, last picture. What do you think? Again, follow me. This upper and lower esophageal sphincter, high IRP. This normal IRP. So this should be EGJ outflow obstruction. So let's see the peristalsis. No peristalsis, but high amplitude with at distal spastic contraction. This normal, right? So high IRP, non-relaxation, and no peristalsis. So this achalasia type 3, and this esophageal spasm with the normal lower esophageal sphincter relaxation. So taking home message, idiopathic achalasia is rare disease. So all investigation, you have to work up with upper GI endoscopy, upper GI contrast study, and especially for the high resolution manometry. And treatment is only palliation. The prognosis, as you know, type 2 is the best outcome, type 3 is the worst outcome. Okay, thank you for your attention.
Thank you so much, Dr. Pornthep, to give us the overview about achalasia. As you know that achalasia is quite have the complicated for the diagnosis because the symptom is might be mimicked from others cause. What is your suggestion for the first investigation for this disease?
Then I mentioned you have to classify. Most of the achalasia come with dysphagia, but if not end-stage achalasia, they're gonna have esophageal dysphagia, not oropharyngeal dysphagia. If the patient with oropharyngeal dysphagia, you can start with upper GI study because we don't know what's going on at the upper esophagus. If you blind upper endoscopy, you can perforate the esophagus. But for the achalasia patient with esophageal dysphagia, you can start with upper endoscopy and make sure no pseudo-achalasia that I mentioned, especially for the cancer at cardia. That you can aware in the elderly patient with the short course of the symptom of dysphagia.
Thank you.
Do you have a question, more question from the floor? For audience in the Zoom, you can also send a question in a message, and our staff will collect the question. Then our lecturer will respond it later. Okay. If there's no more question, I would like to proceed to the next session, so we can stick to our schedule. Okay. Next lecture will be endoscopic treatment for achalasia, Inject, Dilate, or poem. Our lecturer for this session will be Assistant Professor Chainarong Phalanusitthepha with he is a general surgeon at the Minimally Invasive Surgery Unit, Department of Surgery, Sirat Hospital, Mahidol University, Bangkok. He is considered the pioneer of the poem treatment in our country, which is considered the cutting edge technology at the time. So after 2 years, the treatment become famous, and he considered a great contributor to our society. So please welcome Professor Chainarong, please.
Thank you very much for a nice introduction. And thank you, APELS, for giving me a chance for share the data today. Today's topic is endoscopic treatment of achalasia. As Professor Pornthep said, that is because of this Dilate disease, which have a decreased relaxation of lower esophageal sphincter. And they present with dysphagia, regurgitation, weight loss, and chest pain. They divide into 3 types, as mentioned before, and type 2 is favorable type. There has several treatments to treat achalasia since in the past. Today will focus in medication and endoscopic treatment. First is the medication treatment, which is they suggest that we use the 2 medication, which is nitrate group and calcium channel blocker, to treat to use to relaxation of the lower esophageal sphincter. When we use the calcium channel blocker, we have to use it before meals about 30 minutes. But if in nitrate group, we can use sublingually before meal about 15 minutes. Both result in relaxation of the smooth muscle. So somebody of our patient will have headache or orthostatic hypotension. The comparative study of both drug is comparable. So you can use any of drug that available in your hospital. In 2020, there has several guidelines from many society in the world, from European group, American group, Asian group, and so consensus in 2019. They say that for the medication use, we don't use for definitive treatment. We always use only during treatment, waiting for the definitive treatment, such as endoscopic treatment or surgical treatment, or those who are sparing for people who are unfit for surgery. The second choice is the botulinum toxin, which is familiar in the cosmetic treatment, right? We use the gastroscope insert inside and inject 2 point or 4 point of the at lower esophageal sphincter. We inject in the submucosal plane, so after injection, they're immediately effective. So patients always impressed of this treatment, because of you can use this for the ambulatory patients also. After injection, maybe they have some chest pain, but it's only my chest pain and temporarily. The use of the botulinum toxin is blocking acetylcholine release from nerve ending around EG junction, and they improve dysphagia immediately. So, but after 6 months or 12 months, the effectiveness of botulinum is declined. So maybe they develop the dysphagia again, like you use in the cosmetic treatment. So the favorable type of patient is older than 50 years or achalasia type 3. As you see, after 1 month of treatment, the effectiveness is about 82%, and after 6 months is 57%, and 12 months is 48%. So they suggest that after 6 months, maybe we have to repeat botulinum toxin injection again. And as you see, they have maybe tensions chest pain about 20% and significant heartburn about 10%, but it's only temporary. So after you reassure patient that you have to confront with this side effect for a short time. And for the guidelines, they say that we can use botulinum toxin as for unfit for surgery. They in European group, they prefer botulinum toxin and say that we can use as the primary treatment for achalasia, but in other society they not suggest for botulinum toxin in the initial treatment. The third treatment is pneumatic dilation. So pneumatic dilation is very famous along 20 years before this time. It's quite nice and they have a good effectiveness for treatment, especially in type 2 achalasia. We use the balloon to overcome the lower esophageal sphincter tone and to dilate it, lower esophageal sphincter. The favorable type of pneumatic dilation is female more than 45 years and achalasia type 2. If you have 3 factors of this in your patient, you can just suggest them for pneumatic dilation. And as you see, the success rate of pneumatic dilation, type 2 nearly 96%, and in type 1 is only 56%, and type 3 only 29% only. The advantage is less invasive. So in patient is not so fit, you can do the new pneumatic dilation and they're effective in type 2. But maybe pneumatic dilation have recurrence. They say that we have to repeat pneumatic dilation after said that in 5 years we have to have recurrence after pneumatic dilation about 50%. That means you have to repeat pneumatic dilation again, half of them. But in contrast, you can suggest that after treatment we have half of them heal in only 1 treatment also. Every repeat pneumatic dilation, the increase of the incidence of perforation is increased. So in the patient who have very young, we suggest that maybe we have to avoid the pneumatic dilation because of in a long term of their life we have to repeat pneumatic dilation quite frequently. So they may be confronted with the perforation after that. When we compare botulinum toxin and pneumatic dilation, as you see in this slide, the remission after 4 weeks is the same, but in 6 months, the pneumatic dilation is better than botulinum toxin, about 80% to 50%. And at 12 months, pneumatic dilation is 70% and botulinum toxin only 37%. From meta-analysis is the same. The remission rate and relapse rate is higher than in botulinum toxin. And this is also in the same. So the guidelines say that pneumatic dilation is safe and efficacy for treatment achalasia especially in type 1 and type 2. In year 2010, Professor Inoue coined the term peroral endoscopic myotomy, which we call POEM or poem. There is the new concept of treatment achalasia. Actually, the concept is the same as a halar myotomy. We use the gastroscope inside and make a short incision in the mucosa and going in the submucosal plane. And then we make a long submucosal tunnel and going in and do the myotomy. The concept is the same as halar myotomy, so they can cut the circular muscle and longitudinal muscle, keep only the mucosa contact. From the Japanese group, when we do POEM, we cut only the circular muscle and spare the longitudinal muscle. But from Chinese group, they cut it all, the full thickness myotomy, as same as we do in the halar myotomy. The comparative result from both groups is the same, so you can select that you cut only circular or longitudinal. For the long-term result, this paper report in 2016, they say that it's the same. Compare POEM with the lab halar myotomy is the comparative. Clinical success is about 91% in 2 years and 98% in 1 year. This meta-analysis is look like POEM and halar myotomy is comparable. They improve this feature very well, but as you see in this paper, when after treatment for POEM, the improvement of dysphagia is 93%. When compared with halar myotomy, is 91%, and 2 years is 92 with 90%. But it's not good all around because of the presence of the GERD after treatment of POEM. When we test with clinical endoscopic examination and pH monitoring, the presence of GERD about actually overall about 30%, but for clinical symptom is only 5%, which this group 5% we require the medication, and when we treat with the PPI for a short time is improved. Maybe they have to receive PPI lifelong, but in my experience, sometimes we treat for a short course, maybe 2 or 3 months. After that, they can stay without PPI or intermittent PPI. For the length of stay is quite the same. In achalasia type T is a very poor prognosis, but after POEM we can cut a long myotomy, which is a good treatment for achalasia type 3. So in achalasia type 3, POEM is maybe the good choice for treat that. For the guideline, every society say that it's the same comparable efficacy to the halar myotomy. Ladies and gentlemen, I would like to conclude that the current guidelines say that now the standard treatment still halar myotomy with the partial fundoplication, but if you see POEM can show the better improvement of dysphagia and the symptom is better, and is a good choice for treatment achalasia type 3. If we focus in the HRM, we can say that type 1 and type 2 we can treat in many modality. But in type 2, we suggest that pneumatic dilation is a good choice for only type 2. And for type 3, POEM is a good choice. Thank you very much.
Thank you very much, Professor Chainarong, for a very informative lecture. Before we have a question, I have many questions because this is a very interesting topic. First, I would like to ask your own opinion about. I think most of endoscopies not really sure if we should start POEM or not if we already have a very good result from pneumatic dilatation, because you already show a very good result from pneumatic dilatation, right? It's quite a safe and very fast, much faster than POEM. Can you give us some advantage of POEM over the pneumatic dilatation?
Thank you. So, POEM is the concept of like a Heller myotomy, so they last longer than pneumatic dilation. So, for the indication, maybe we suggest that in the young patients, maybe we need surgical myotomy. For Heller myotomy or POEM is better than pneumatic dilation. And if you don't have people to do POEM, maybe you have to send to pneumatic Heller myotomy. And for type 2 achalasia and they age more than 45 years and female, maybe pneumatic dilation is good choice for them. Mm-hmm.
Thank you. So we can say that it's very good. POEM is very good, maybe the best in type 3 because it can do much longer myotomy, right? And very good for younger patient too. You also show that POEM, after POEM, patient experience, many patient experience GERD, right? Mm-hmm. And I just heard the new about we also can do the fundoplication from the endoscopy too. Many small report of the case, a series of the case from our pioneer innovator. Do you have any experience, or could you share some of your insight with us about endoscopic fundoplication?
Actually, since 2010, we have many techniques for do the endoscopic fundoplication, and they have report in 2014 that we can do we call POEMF, that we use we enter to submucosal tunnel and going out and catch the cardia back to the esophagus like Fundoplication. And actually the result is very good, but it require higher skill for do the endoscopy and have what we call learning curve is very high. So they're not popular because of most endoscopists they cannot repetitive this so much. So I think we waiting for a new technique for endoscopic fundoplication. I hope that maybe it's coming soon.
Yes, so it will not become a standard of treatment in recent day, right? Still a long way to go. It is somehow still a good news for some lab surgeon that we still have an edge over the endoscopic surgeon, right? Okay, so we can we can say that for the type 3, we can do much longer myotomy. But how about the concern about the tunneling? If you do longer myotomy, the tunnel will be shorter, right? And is it affect how safe of the procedure? Is it have more complication about the leakage if you longer myotomy?
The concept of the treatment in longer myotomy is the same, but because of in the upper esophageal, the muscle is quite thin, and especially in type 3, it's not thick like type 2 and type 1. So maybe they have more complication, especially from air, I mean CO2 insufflation. Maybe they have more pneumomediastinum and pneumoperitoneum. But by the technique is more difficult than ordinarily, is not so much.
Thank you, Professor Chainarong. I have some question for you. Because some of our hospital don't have the regiflex. Mostly in our hospital have just the CRE balloon. Should we use the CRE balloon replace the regiflex balloon?
So we can try that also, but from the standard they say that regiflex have good result more than CRE balloon, especially in the bigger balloon. Because of in Thai people, we also use only 3 centimeter balloon, and 3.5 maybe not, but maybe sometimes it's too big for that. CIE balloon size 3 is maybe difficult to find that also.
Thank you so much. And any questions from the floor? Dr. Pornthep, please.
Thank you for informative presentation. May I ask about type 3 achalasia that we mentioned? We know the best treatment is POEM, and the problem is growth after that. What do you think about the POEM combined with laparoscopic fundoplication?
That's very good question. So most of people say that when we do POEM first and waiting for the result. If the patient have severe GERD, maybe we gonna go for lap fundoplication after that. In expert opinion, they say that only some patients, maybe less than 5% require the lap fundoplication.
I may share some my thought on this topic, because still even I think even we have type 3 achalasia, the lap surgery still perform not very bad. I mean 7 to 80% still respond to the treatment too. So I think it may be more justified to go to lap first, and if it not your patient fall into 20 to 30% that is not respond to the treatment, we can use the POEM as a backup if we like still prefer the lap surgeon over the endoscopy for the institute, because it seems a little bit weird if you like to try to go to lap surgery after POEMs just to take care of the GERD, because we know that after a year or 2 years GERD will be better. So there should be some kind of research to back up this treatment strategy. Thank you.
I'm totally agree with you. Maybe we try to do the lap myotomy first, and then if the result is not so good, we coming back with the poem in the proximal muscle to cut the proximal muscle after that.
Thank you very much, Professor Chainarong. Today, morning session is maybe finished here, and we will take a break for maybe 15 minutes, and we will go back again for the surgical myotomy, the surgical treatment for the hiatal hernia, and the fundoplication. Let's take a break and come back again.
I would like to welcome everybody back into our Endo-Lap management of gastric submucosal lesion and common upper GI disease. Again, this is now day 2 of the conference. Next session, we are going to go to lectures about the surgical treatment for achalasia, the Hiatal myotomy, which is our mainstay of treatment, how I do it, by Professor Kanokkan Tepmalai. May I introduce Professor Kanokkan a little bit? She is assistant professor in the MIS unit and the pediatric surgical unit, Chiang Mai University, Thailand. She graduated from Chulalongkorn Fellowship Program and continued her education in Japan about the endoscopic surgery in Kobe. Now she holds an executive committee in the Associate of General Surgery of Thailand and also TS MBS of the Thailand. Please welcome Professor Kanokkan Tepmalai, please.
Thank you, Dr. Bandhuphat, and thank you, APELS and Professor Suthep Udomsawaengsup. My topic is about the surgical treatment for achalasia, Hiatal myotomy. I have no disclosure for this topic. For achalasia, the pathophysiology is about they think it's related with the genetic predisposition and environmental trigger, such as the viral infection. It causes the autoimmune myenteric plexitis. This one can cause the neuronal cell death. If we can demonstrate that neuronal cell death, it can demonstrate in type 1 achalasia and type 2 achalasia. But if it causes inflammation, it helps the imbalance of between the inhibition and excitation. We will see this pathological in the DES or the type T achalasia. This pathophysiology of the myenteric plexology. As you can see that the type 2 achalasia, you can see the neuron cell, but the type 1 achalasia, you cannot see the neuron cell, which means it's caused the neural cell death. For the immunohistochemistry staining, you can see it stains CD3 and CD8, which means it has the inflammation. For the surgical treatment for the achalasia, the goal of our surgery is just to improve the distal esophageal obstruction by cutting the circular muscle fiber to lower the esophageal sphincter pressure. We can do it minimally invasive approach or the open approach, which if we relieve the esophageal sphincter pressure, it can cause the GER. As the Dr. Pornthep said, it's around 50% of the people have the GER. Mostly we did the anti-reflux procedure performed with the myotomy. So when we do the treatment for achalasia, we have the balance about the LES pressure sphincter to improve the dysphagia and minimize of the reflux, the GER. For the myotomy versus the endoscopic treatment, yes, the myotomy is lifelong and durable, which has less reintervention. than the pneumatic dilatation or Botox injection. And the SAGES guidelines suggest that the laparoscopic myotomy and partial fundoplication is the procedure of the choice. We can do 5 different technical approaches, such as the open abdominal, open transthoracic, or the laparoscopic or thoracoscopic. And now they use the robotic approach to do the myotomy. For the laparoscopy, it has a shorter hospital stay and shorter complication. For the transabdominal and transthoracic, they think that transabdominal it improves the post-operative reflux control by the additional of the anti-reflux procedure. This is the comparison between the treatment. As you can see that the surgery has this improvement of the symptom relief, and the post-operative GER is less than the endoscopic one. And for the thoracoscopic or thoracic myotomy, it has the higher rate of the GER than the transabdominal approach. This is the anatomy of the esophagus. As you know that it has longitudinal muscle outside and a circular muscle inside. So you can cut the longitudinal and the circular muscle to relieve the pressure at the esophageal pressure at the lower esophagus. For the hiatal dissection and hiatus hernia repair, mostly if we do the repair of the hiatus, it can cause the dysphagia. So mostly we don't repair the hiatus. But if it have the hiatal hernia concomitantly with the achalasia, so you can do the repair. Or if you need to do the repair of the hiatus, you need to emphasize that it's not be too tight because it can cause the achalasia. This is the crust of the diaphragm, and we need to do the minimal dissection of the hiatus because it can cause the reflux. This slide show if we do the dissection at this area in the wrong way, so we can go to the thoracic. But if we do in the near the stomach side, you can have some bleeding because at the stomach side has the many vessels. So we need to keep it close to the crust of the diaphragm. And when you do the dissection, you need to beware that it has some vascular and neurovascular. So you need to protect them and try to dissect by not injuring them. This is the neurovascular cause. And after we can encircling the esophagus, so we need to do the elongation of the esophagus. So we need to cut around the esophagus, but we need to beware that the lateral part of the phrenoesophageal membrane and posterior phrenoesophageal membrane, we need to preserve some of the fiber. And then we will cut the fat at the stomach to prepare to do the myotomy at the gastric site. So this video shows how to do the dissection around the esophagus. We open the parafaxilla, at the lesser curve, and then we do the dissection at the right crust of the diaphragm. And we open the peritoneum that cover the esophagus. And trying to cut until you see the left crust of the left crust of the diaphragm. And this video performed by Dr. Bandhuphat. This one is quite beautiful, and I just fast it forward to just it's fast forward. Do not trim it. It's quite. You just keep it close to the crust of the diaphragm, and then you will go out and encircling it. This one is, it look easy, but it's not easy like that. So you can do the dissection, make it open and encircling the esophagus. It takes just less than 20 minutes, like this. If you do it the wrong way, you can go to the thoracic part and you can injure the vessel, or you can go into the thoracic part. And after that, we will do the myotomy. If you can see that the laparoscopic can improve our vision about the muscle fiber. As you can see that, you can see the muscle fiber, the longitudinal muscle and the circular muscle. You should identify the circular muscle and try to cut it all fiber, because if you left some fiber, it can cause the dysphagia. And you can do it with the cauterization, or you can use with the harmonic scalpel, or some surgeon do it by just use two grasper to pull it off, but it has some bleeding, so you please be careful about that one. The recommended length of the myotomy is around 4 to 8 centimeters at the esophagus, and around 0.5 to 2 centimeters at the stomach side. If the fiber change from the circular horizontal muscle to the oblique one, you will know that you enter to the gastric side. As you can see in this one, the oblique fiber, this one, the oblique fiber, and you need to cut it all, because in the muscle at the gastric side is quite attached to the mucosa. So please beware at the gastric side, you can injure the mucosa easily. When we do by the harmonic scalpel, we need to cut the longitudinal muscle first, and then we will try to identify the circular muscle inside. If we cannot see, we will cut the longitudinal muscle again, and then you can see that this is the circular muscle, and cut it through up to around 4 to 8 centimeters. So you can cut as long as possible, but we cannot cut like the poem, which is around 15 centimeters. We cannot do that. But as you can see, this is the circular muscle. If you use the 4K machine, so you can see the muscle fiber is quite clear. And this one is the gastric side. As you can see that it's quite stick with the mucosa. You need to be careful when you do the myotomy. So you should try to cut all the fiber, because in the gastric side, if you don't cut it all, you can cause the post-operative incomplete myotomy. So you see the all fiber will cut. We need to cut it all. If you beware about the injury of the mucosa, some you can use the grasper to retract them. Someone use the perioperative manometry and endoscopy to check the completeness of the myotomy. If you do with the endoscopy, you can see it that it wide open the EG junction, and it can check the perforation at the time. But sometimes they recommend to use the lower esophageal manometry, but I think it's quite difficult to apply it in our practice because some of hospital have no manometry in their hospital. For the fundoplication after the myotomy, mostly they recommend to do it because it can protect the GER from the post-operative myotomy, because the rate of the GER is higher when it has no fundoplication, around 30% versus 8%. But if you do the myotomy with the fundoplication, beware the risk of the dysphagia. For complete and partial fundoplication, which means the Nissen fundoplication. For the partial fundoplication, mostly they do the door or the Toupet fundoplication. For the anterior door fundoplication and floppy Nissen fundoplication, the rate of prevent for the GERD is quite the same, but the risk of the dysphagia rate significantly higher in the Nissen fundoplication group after we do the Achalasia myotomy. If we between the partial fundoplication door and the Toupet, they think that the outcome between door and Toupet is quite the same when the relieve the symptom and the dysphagia rate. But when they study about the reflux from the door fundoplication, they found that it has the abnormal reflux from door fundoplication than the Toupet, but it's not statistically significant. When you do the partial fundoplication, the door fundoplication is quite quicker and easier procedure, and it's not more disruption of the hiatal anatomy when you do the Toupet. So please be careful. And if you have some injury of the mucosa, such as the perforation, the door fundoplication is the choice because it can cover the mucosa. But for the Toupet, you will expose the mucosa outside. This is the door fundoplication. You see the video again. And this is the Toupet fundoplication. For the Toupet, you can see that the mucosa will explode, and you need to bring the fundus to cover the posterior part of the esophagus for the Toupet. And this is the floppy Nissen fundoplication. For the predictor of the successful outcome after myotomy, mostly they think that if the patient has lower LES pressure or the patient has the dilated of the esophagus, it can have the poor outcome of the patient. And something that if they do the balloon dilatation or Botox injection before myotomy, it can cause some complication more than the patient did not do the endoscopy. For the effect of endoscopic treatment before we do the myotomy, mostly think that it can cause the intraoperative complications such as the bleeding or the perforation, because they think that the botulinum toxin can cause the inflammation around the esophagus, so it can obliterate the plane when you do the dissection. But mostly the surgeon think that it depends on the surgeon experience to do the surgery. It's not depend on the endoscopy. This case is the post-balloon dilate 3 times. Some of the plane are obliterate, but it can do the myotomy successfully, but maybe it have more bleeding than the one who did not do the balloon dilatation. This is the perforation from the previous endoscopic that they reported it higher rate of perforation than the no previous endoscopic treatment. Oh, okay. For the perforation, we will just do the repair. Just do the repair and do the 1 stitch or 2 stitch by the Vicryl 4O, and maybe it result in longer hospitalization. For the outcome, when we do the myotomy, it can normalization of the symptom of the patient, but it can cause the significant reflux is around 9 to 17%, but it can manage by the medication. Some they have the recurrence about after the laparoscopic myotomy, so it can caused by incomplete myotomy, or it can caused by the myotomy fibrosis, or the fundoplication disruption, or two-type fundoplication. If you do the myotomy, you need to do the longer follow-up because the outcome is poorer when the times is longer time, such as this is the RCT by Dr. Sendes show that the outcome is bad when the after myotomy is around 15 years. It has from the bad result is from the severe reflux. And the reintervention rate is quite high, especially in the children or younger patients. This is the high resolution manometry preoperative. This patient, she is 18 years old. We did the high resolution manometry preoperative. As you can see that she has no inhibition. The IRP is quite high, 40. And she has the column, the pressurization. She had the type 2 achalasia. And this one is the post-operative HRM. So as you can see that she restoring the peristalsis after we did the myotomy. It had some literature, it said that if you do the treatment for the patient type 2 achalasia, it can help the partial recovery of the peristalsis after treatment. So for the type 2 achalasia, we need to do the operation or the treatment before the patient getting worse or turn to the type 1 achalasia. So this is the one of our patients we can demonstrate that it can help the peristalsis after the treatment. And this is as you can see that the IRP is around 40 in the preoperative, but the postoperative, the IRP declined to just 11. So if we have the manometry, we can do it pre and post-operative to check that after we do the myotomy, the residual IRP is lower than the preoperative. And for the outcome, if we can lower the pressure at the LES less than 15 is have a good outcome. The patient can relieve from the dysphagia. And this is how we do the door fundoplication. So this one, we suture at the left side, and then we flip the fundus to another side, and cover the mucosa, and do the suturing. So this is the door fundoplication. Actually, I trying to I have some demonstration of the perforation of the esophagus. So if you can detect this one, you can do the suturing. But if you can detect this one, the patient may have the bad outcome after we do the operation. So we need just one stitch to repair it. So please be careful when you do the myotomy. It can have some perforation. If you do not be sure that the injury of the mucosa or not, you can do the endoscopy to check it before you close it or before you do the fundoplication. So this is the important one. Okay. For a conclusion, I think it is important to remember that the treatment for achalasia is just palliative, it's not curative. The patient needs long-term follow-up. After you do the treatment of the patient, you need to follow up the patient because the reintervention rate is quite high in this group. Maybe 5 years, 10 years, or 15 years. Thank you very much.
Thank you very much, Professor Kanokkan, for a nice video showing here. Today we have many experienced surgeons here. I would like to ask Professor Pornthep to share his tip a little bit about how to enter the submucosal layer, which sometimes I found it difficult, and also if we face the situation like we unintentionally did a perforation of the mucosa, how we deal with it. Okay, please, Professor.
Hello. Okay. Thank you for very nice video presentation. So my technique, first I have to wrap the EG junction and let the assistant help to traction. So traction, counter traction, very important. And then it depends, you can stand on the right side of the patient or at the midline. And first, I'm gonna start myotomy above the EG junction because it's more easier than close to the gastric part. And before I use the ultrasonic shear, I use the Gasper and dissector and make some tunnel and dissection layer by layer. And then because if start with the ultrasonic shear, sometime at tip of the ultrasonic shear, it's gonna burn the mucosa. So I'm gonna create the tunnel space first with the dissector.
And if you we did the perforation at first attempt, we try to enter into the submucosal layer. How about your opinion about some of surgeons' advice that we may try to close its full layer and then start doing the myotomy at the different place? How about your opinion with this one?
I think if I found the perforation, I'm gonna start at the new position first and create up and down. Because for repair the defect should be repair only the mucosa.
Okay.
Not stitch all the muscle.
I agree because sometimes some of the surgeons suggest that we should try to add the other angle, which sometimes make the procedure more difficult. Do we have a question from the floor? This question is for Professor Kanokkan. How about your opinion about the dissection to cut the short gastric vessel to perform the door fundoplication? Do you have ever experienced a difficulty that you cannot move the fundus freely to cover the myotomy part?
I think mostly we can do the fundoplication without to cut the short gastric vessel. Mostly, I think, but sometimes when we do the Nissen fundoplication, some patients have some short gastric and maybe we can cut it, but mostly I don't cut the short gastric vessel to do the fundoplication.
I also have some tips to share with you. Some tips because I use solely only harmonic scalpel to do the dissection. I try to use first when I cut, I try to turn the jaw into the other direction to cut only the longitudinal muscle. I found this a little bit help on the dissection, and next you can just turn the jaw back to parallel to the part you're gonna cut, and then it might move in easier. And also the things that Professor Pornthep just mentioned, that he used the dissector to separate between the layer of the mucosa and the muscularis layer first. I do this step by using just the harmonic scalpel, just like in the video. But the tip here is you need to close the jaw a little bit, because if you fully open the jaw have the tendency to penetrate into the mucosal layer. It will gonna cause a problem. So if you close the jaw a little bit, it would be slip easier into the layer in between. I also would like to ask Professor Suthep to give us some tip on this procedure too. Please, Professor Suthep.
Thank you very much, and also congratulations, Bandhuphat and Kanokkan, for a very nice video. So I think variety of techniques will be available for you to choose. I'm also using the same technique, but when we do first bite or first cut on the myotomy, yes, I do with the cautery. So it's a kind of a difference. So I use hook cautery. Started with the longitudinal one, and then you have to have a look on the circular muscle, which need to be open. So at that point, I use a hook and trying to separate the circular muscle from the mucosa. The mucosa itself, you can appreciate what Kanokkan and Bandhuphat has been shown to us. It's going to be a very thin layer of the epithelial with the capillary vessel on that, so that's the mucosa. So then you separate the mucosa of the muscle, then I hook the muscle up and just use small cautery on that myotomy. So that, I think for myotomy, it's the best and very present operation for us for upper GI surgery. So I would emphasize that we should try to do it beautifully and happily. Thank you very much.
Thank you, Professor. And we proceed to the next session. Okay. Thank you, Professor Kanokkan, again for a very nice presentation. Now, the next session will be the lecture. The topic is things should be considered and surgical pearl in a hiatal hernia from our well-known Professor Suthep Udomsawaengsup. I would like to introduce him again a little bit. He is the director of the CUMAS Center, board member of APELS, governor of ELSA, president LES, governor of APHS, president of APMBSS, secretary in MESTA, and also our teacher. Okay, please, Professor Suthep.
Thank you, Bandhuphat. Thank you, Kanokkan. Thank you again for joining us today. We've been waiting for a very long time for gathering back in this room again, and we make it now. Thank you very much. So, things should be considered. I stopped this point and then I said, thing we should consider is that we need to thank the Asia Pacific Endo-Lap Surgery Group, or APEL, for having us this very nice workshop today, also yesterday at T-TEC. It's been a long time, since January 16, 2016, here in Bangkok, where Professor Lee and a group of laparoscopic endoscopic surgeon, we together celebrate the inauguration of the group, and they've been very much contributing to the field of Endo-Lap. Thanks, Professor Michael Lee, for the initiative and keep contributing. This is the board member has been discussed early this year, and then they granted us the localized module today here. So thank you very much. I will be looking forward to seeing all friends here in person very soon. Professor Michael Lee, we will be waiting for you here in Bangkok. And once again, thank you, Bandhuphat, Kanokkan. This is our course director. They've been working very hard because it's the first APEL module in Thailand since the pandemic. So if you enjoy the program, please make a big applause for this to ladies and gentlemen, please. Thank you very much. And also very happy with the workshop yesterday with the subepithelial tumor. It's a beautiful one. I would say most beautiful subepithelial lesion you see in these photos. Next thing we should consider for hiatal hernia, we focusing on hiatal hernia, not the refractory disease, which is going to be another. It seems to be similar, but there are several differences in these two diseases. So let's start with this lady. She is 45 years old. She came with epigastric discomfort, especially after meal, for at least 4 or 5 hours. So I went to the primary doctor, and then the medication has been given, but she's still having the same symptom. This is quite common. That's coming to us. First film, you can see that the plain chest X-ray, you can see some air actually in the mediastinum. So at that point, we know that it's going to be hiatal hernia. So tests will be done. You can see that we do upper GI for our interest. You can see the whole stomach herniated into the mediastinum. So this is clearly the hiatal hernia. And also you can see in this part, that's why causing the symptom. So I think for hiatal hernia, especially for a case like this, it needs to be fixed, no doubt. And what we have to do, this is the scope that we put the scope down. I'll pass quickly down into that part. So you can see that this is C-line. It seems to be normal for the C-line, no esophagitis. But anyway, when you go down, you will see another pouch, huge one. You can see that. We can see the narrowing on the second portion. That's the crus of the diaphragm. So I think the endoscope would be very much helpful, and then we'll put down the scope. This case still have the severe esophagitis. Anyway, because of the symptom, we have to have the patient for the treatment. So this is a view from the endoscopy. So first, what we need to realize or consider, it's about anatomy. Anytime I'm talking about hernia, this is one of the category of the hernia in the abdomen. So we need to talk about anatomy. Similarly to inguinal hernia or ventral hernia. So this is the esophagus. Let's see. I don't have that. Sorry. It's okay. I think let's see how. Sorry for this technical. Let's see how I can do this. Cannot. It's okay. Okay, so let's see. I'll try to show how to do. Let's see. Because I need to show this, at least this photo. I don't know how to. Cannot come. This is the main thing about the anatomy, but oh my goodness. Sorry about the technical issue here, but what I would like to emphasize is the photo number 20, which focusing on the phenoesophageal membrane. You're talking about phenoesophageal membrane, and if you keep drawing or continuing the abdominal wall, started as we familiarized with the inguinal hernia, and we've been familiarized with the transversalis fascia. So this is part of the transversalis fascia that separate into two. One is ascending to hook or to attach to the esophagus on the upper part. The other one is going down, so it's having the descending and ascending membrane. I think this one gonna be showing the photo. So again, transversalis, this is from anterior abdominal wall. We can see that it is the same membrane as shown here from the anterior abdominal wall. So this is very important and the fundamental that we need to understand. Fortunately, doesn't show. It's okay. I think we skip all this and then. Okay, I think this photo also showing. So you can see from the fiber, actually the cardia and the fundus of the stomach has been herniated into the mediastinum. So this is the anatomy defect causing physiologic diseases for the patient. For long term, it's going to be hooking everything up into the mediastinum. The second is the function of the lower esophagus will be changed. Would be known that the pressure of the abdomen is positive. That would empower the function when they going to the mediastinum, which turn to be negative pressure. That also impair the function of the lower esophageal sphincter. That cause the reflux to be happening. So you can see that the reflux disease and this hiatal hernia, it's kind of a variety of disease that sharing the same principle. Sorry about the anatomy that's been lost from the my presentation, but anyway, hiatal hernia secondly is about the principle of the treatment. The physiologic problem causing from the anatomy is that it causes the reflux, so we need to prevent reflux. So we need to have the LES as well as the lower esophagus into the abdomen to empower and reinforce the function of LES. And also we need to have a high pressure zone in the LES to prevent the reflux. So the disease of achalasia we've been discussing very in detail, and hiatal hernia is kind of another disease, spectrum of disease. So this is what we are here for, the benign diseases, which is very interesting and still very much practical, or the diseases that we need to fix. So the technique itself for hiatal hernia repair, it's first to reduce the hernia sacs. Same principle for any hernia repair, reduce of the content in a hernia sacs. Number two, for us, I believe that sac removal is very important. The last is the crural closure and the fundoplication. So let's see the setup. Step by step, this is the setup for upper GI surgery. You can use French position, but for us, it's the standard technique of doing the upper GI surgery. For any upper GI surgery will be like this. This is the picture to show how we do the procedure. Yes, this picture is very important because I have Dr. Chadin, the head of the division here too. The procedure itself can be step by step. So you can go into the abdomen. We have the river retractor, and we use Nathanson. Then we do diagnostic laparoscopy. We put 3 more port in. Then we approach to the hernia part, which is the EG junction or the hiatus. Then we do the sac dissection. When we have the sac removed, then we use the non-absorbable closure of the defects or the crural. The only thing different between abdominal or anterior abdomen hernia is that we need to have the opening for the esophagus to come, allow the esophagus and all content to come down. So that's one of the very debatable or very challenge, how to make it enough tight but not too tight. Lastly will be fundoplication. So I'm always saying that for hiatal hernia, it's comparable to peristomal hernia. So when you close the defect of peristomal hernia, you need to be making sure that the opening is still enough size to allow the content to be going through. So this is the technique started with the, I think you'll be familiarized with the under direct vision access into the abdomen because we off midline, so we're going slowly into the abdomen safely, then we put Nathanson. And see that for upper GI surgery, you can use any type of river retractor that you're familiar with or it's available in your place. But for us, the rigid retractor like Nathanson is very helpful. So to take care of left lobe of the liver, then diagnostic lab will be done, making sure that you have a look, take advantage of going in and have a look. Then we'll put 3 more ports. You can see that it's going to be 2.5 and 1.2. This is the incision. Then we start the operation. Interluminally, what we have to do is that, well, first thing after doing the diagnostic laparoscopy, we're doing the reduction of the contents. You can see that we gently pulling the content back in, and then we start with the gastrohepatic ligament. So you may discuss about the accessory hepatic artery here, but anyway, in those cases, we prefer to preserve the artery. Then we start with the ricus, same principle, using the ultrasonic devices, try to preserve the peritoneum on the cus. Then what next? We keep dissecting, I think, similarly to the Myotomy. So you can see that we follow the curve to the left cus, keep our cell on the sacs or the peritoneum. Then you can do the sac resection. Seeing that the sac, slowly you can take care of the sac to go in, and you make sure that that's the aorta has been seen with the white color down underneath. The sac will be taken back in. So this is a sac. Try to get the sac in, and then we dissect, making sure that we are not injuring to the pula. The principle of us is that stay next to the peritoneum or sacs, similarly to the technique of the inguinal hernia. Sac is the peritoneum, so just stay next to the peritoneum and taking the peritoneum back in. Next will be the esophagus, and you will see the esophagus has been taken down in place. The hernia sac itself will be separate from the esophagus, and all sac will be taken back into the abdomen. After that, you can see we also using the pillows, so you can see the esophagus there, and the vagus nerve located side by side of the esophagus. When you pour it, you will preserve and you protect the nerve. The sac will be taken back in, so all content will be reduced, so that the technique, and you can see the vagus nerve will be preserved. The next step will be the closure of the crural. So this is a crural closure using non-absorbable, and we use the hand saw technique to introduce this closure. And next is how many stitches. I think it, and also how we make sure that the size of the opening is not too narrow or too large. So I myself mostly will have a look. That's number one. You may put the sizers, which are also very helpful, but for us, we use just 2 or 3 stitches to narrowing or to close the opening of the crural. I'm not touching about the mesh or non-mesh, because that is another debatable. But to me, if it's larger than 5 centimeters for the defects, so we will put the mesh. So this is another case just to share some experience, and then I think there would be several discussion on how to deal with. The principal technique would be similarly. We started from the gastrohepatic ligament, going and opening this gastrohepatic ligament. Then we will expose to the cus, and we start with the cus. So let's see, that's the cus. Try to get the cus, the peritoneal opening. This is one technique that we use, just use the open jaw and then put the energy that will be having a cavitation of that tissue. So same principle, going in, and then the assistant from the left side of the patient would take care of the peritoneal, stay on the peritoneal, then we will be able to take care of the hernia sacs. And the cus, the V shape down here, when we have the cus exposed, we introduce same principle, the pillows. And the pillows will be handling by the assistant from the left side, pulling downward. You can see that the grasp and the pull down, then it accommodates the dissection of the hernia sac better, and also this maneuver will preserve the vagus nerve, but actually you will see the nerve clearly after having it shown. Let me share, this is another video, and then we will have you the experience. So last week, hernia repair. Thanks Anus for having this video prepared, and also you also having the reward from the Royal College of Surgeons, right? This is 70-year-old ladies presented with the dysphagia same. So mostly why I'm saying that the refractosis is kind of the medical treatment right now is debatable, but for hernia, for anatomy defect, I would say that the surgical treatment would be very effective treatment. You may follow us, and then you will experience the same principle. Started with the you can see this is small intestine, those organs been in, so that's a hernia defect. So let's follow what Saranut has been showing to us. We're getting into the defects and have a look. Then gastrohepatic ligament will be taken, and that's the cus. Same, you can see open the jaw and then apply the energy. It have a cavitation effect. Then the assistant will pinch on the peritoneum or the cus. And same thing, the active breath will be under always the direct vision. So this case, I think it's kind of a bit huge and very difficult to get to the posterior of the stomach or retrogastric space at the cus. So on the left cus, we switch. I myself, I take care the pinch on the peritoneum, and the assistant will take care of the cus. Then the posterior of the hernia sac will be taken. It actually this case is big, so that's why we switch our technique a little bit. You can see spleen. Actually, spleen has been herniated outside too. So after having the pillows in place, and the assistant will be able to get better maneuver to take care of the hernia sacs. Then we try to slowly remove the hernia sacs. In this case, it's been a big lipoma in the sacs. So that's why it's a bit tough, but slowly and carefully we can reduce all the hernia sac back in. Then after having a sac in, what next? You can see from the mediastinum, even the nerve will be demonstrated and preserved. So the fiber next to, that's the esophagus, the aorta, and the pula. So all structure will be identified and preserved. We need to have at least 2 or 3 centimeters, as mentioned earlier. And the nerve, when you have the pillows in place and manipulate with the pressure, the nerve itself, it will be very much protected with the esophagus. So you can see, then we remove a sac. I usually remove the sacs from the esophagus and the stomach or cardia. So that will be almost the end of the procedure. After that will be the fundoplication. So all hernia sac will be taken back in and it been removed. So that the hernia sacs, the omentum from, and for this huge hernia, we usually use Nissen fundoplication for the patient. And we'll be discussing about the fundoplication later on. So these are defects that we will close. So just adjust the needle and going in, try to get the peritoneal to be reinforced with the cus. And you can see that the cus itself is still very healthy, so it can accommodate the closure very well. On the left side, you will see the IVC, so I have to be making sure that you push it away. I see that normally I'm not leaving my needle out, but in this very particular procedure, I keep my left hand pushing on the vena cava, so then we can making sure that the needle, the tip of the needle doesn't come into any risk. This is the procedure. We make normally 3 stitches. Then we step to the fundoplication. As mentioned earlier, that we apply Nissen fundoplication. So pulling the lower esophagus, making sure that you have enough length, and then let me have a look on nerve and those things. We do a cut on the short gastric, as discussed earlier, that we do a Nissen fundoplication, making sure that it lose very, very floppy fundoplication. And then we apply a stitch on the fundoplication, you can see. And we can discuss later on for the technique where the fundoplication stitches will be, and also should we put the stitch on the esophagus or not. So we start with we call it the air stitch, which not touching the lower esophagus, but the second one and the third, the second and the third will be touching a little bit. So you can see that very floppy fundoplication. So we use the this bulky of the fundoplication to prevent the herniation as well as to reinforce the lower esophagus sphincter. So this is the stitches. And then we'll remove the penlos. The gastropexy to the cus, it not our routine, but in case we are having a look on the fundoplication, but it's still not in the very appropriate procedure. We're also putting one stitch in here, and you may have seen several techniques for the gastropexy. At the end, the sacs will be removed, and that will be the end of the procedure. We finished this one, and then I think, yes, here I'm pretty much sure that you're also doing bariatric surgery. We upper GI surgeon, the bariatric procedure is also one of the benign cases that it's very giving you ability to take care of the patient. Ladies and gentlemen, in next year, 2023, May 25th to 27, Rayong, for the Asia Pacific Metabolic and Bariatric Surgery Society, we may have an APEL to join or to support as part of the activity. Thank you very much.
Thank you, Professor Suthep, for very inspiring lecture. Do we have questions from the floor? Okay. Very nice video indeed, and actually I have learned a lot from like many years since we first started collaboration. But something I remember that a little bit different in this video is I see no mesh, right? No mesh for today. I remember that back then, maybe 5 years ago, I remember that you put the mesh in like 80% of the case. I probably asked a question about how the education going on today and how you choose the case for putting med in, and did in recent year you change your practice or not?
Thank you very much for throwing the issue of having mesh or no mesh for hiatal hernia, which are very tough and very difficult topics. I've been involved in the debate about mesh or no mesh, and I have a study review, and it divided into group. Those who always putting mesh will be supporting. The other will be very afraid about having mesh next to the EG junction, especially those who are taking care of the esophagus. So then the practice right now for me is that it depending on the cus itself. If the cus is healthy and it's strong enough to hold the suture, in those situations, I choose not to use mesh. But in the other way, if the cus itself it look very thin, or you may not put or handle the suture, so in those situations, carefully I would choose mesh in case of the defect larger than 5 centimeters. So I think 5 centimeters, it's not the cut line, but it's kind of the guidance for me to decide using or not using mesh, and also depending on the crural condition. If you use mesh, yes, of course, you have to have the tissue barrier mesh. I'm not using, or we are not using the biological mesh, which used to be suggested. But right now, I think there is no more suggestion on that part because it will be, not much reinforcement. So then the tissue barrier mesh will be in place. Then if you use mesh, tie the mesh, how to fix mesh, and also how to cut the mesh. It's also giving into the consideration how to prevent the erosion of the mesh into the esophagus. So if you put mesh, I use the inverted U and try to get the edge of the mesh to not to be facing to the esophagus. So the stitch itself need to handle the esophagus and also the mesh to be making sure that the risk of erosion, it should be very low. So it kind of several discussion and it's still not much evidence to support. So it depends on group of physicians who are favoring on this part. Then our practice will be according to the finding interoperatively.
Thank you, Professor. I also the person that very afraid of putting the mesh around the esophagus. How about Professor Pornthep? In your practice, do you use the mesh?
In my practice, I use a Gore-Tex for reinforcement. It's like a U shape and reinforce at the crural. And some surgeons also use like some modality like a T-cell, everything to prevent the staph for the giant hernia. May I ask Professor Suthep? For the giant parasocial hernia, can you recommend what the indication for crural relaxation, or we can only stitch it cross the crural? If we cannot cross the crural nicely, how to do crural relaxation?
Yes, that's also one of the recommendation to do the relaxation on the cruise, especially on the left side, which is be more spacious, and you can put mesh or no mesh on that relaxation. I myself, I haven't had that experience much, so I don't have any comment on that part, but that's the recommendation that the people who are fading off the mesh would recommend that technique. As you can see, mostly if you taking a good care of the cruise, mostly you can having the stitch to be taking for the opening of the defects. So that's my response to that one. If it to fabric or the tissue, the muscle itself is very much weak, so you might put mesh or some sort of blood test, not to cover the defect, but just to reinforce the crural itself. So that's also the technique that has been advised. So it depends, and also you have to have those skill or technique in case that you may need. Otherwise, it might lead you to some challenging situation.
Thank you. And again, for the giant parasocial hernia, do you do anterior gastropexy to prevent its poor herniated the stomach again?
Thank you. Yes, it's been advised again by some surgeon, not me, because I think when you do the closure, you can see that the lower part will be V-shaped, the upper part will be O-shaped. So having a stitch on the shape like the oval shape up top, that's causing a lot of tension. So that's why I'm not doing that anterior closure of the crural. But also, depending, you may have seen some surgeon putting a stitch on that part, but because of the tension and also the angle of the EG junction, they believe that when you closure the posterior part, it hanging the esophagus up and the fundus up, so that they advise that technique. So I think it depending on the situation you may face. In those you see it is very, probably very loose anteriorly. you might put 1 or 2 stitches up top. But that's why it leading me to a very bulky and big floppy fundoplication, to making sure that this also not only reinforce the lower esophageal sphincter, but also to prevent the reherniation into the mediastinum.
Thank you. I have just one question about the, do you face after we do the repair hiatal hernia, and do you have some patient come to you about the dysphagia post-operation and how you manage it?
Thank you very much. This is also happening to parastomal hernia when you use the kosher of the defects. A patient might have constipation. We learn the same situation. Early in our experience, we have had some dysphagia. And what we have done, initially we inform the patient that this might be the good side of the having a good result after having the tissue relax. But actually, it's not that correct. So what we have done is that you might need to have if the patient could not go well with that Nissen fundoplication or any fundoplication, you might need to do the dilation, or the balloon would take care of that stitch very well. But what we have to discuss with the patient is that if you do the dilation of the fundoplication, the patient might have, especially for a reflux problem, they might have a reflux recurrence. So right now we have very uncommon to have the dysphagia after even fully fundoplication, because we make it very floppy. You can see that even if we don't put any sizer in, but the tunnel itself will be very much large enough. So we believe that the fundoplication itself is not the anatomy that you have seen at that point, but it's about the physiology of the function when you have a food particle in the stomach, and the stomach start to have function and causing the muscle to be contract, so that the functional fundoplication will be our philosophy or our belief that we better to do it very loosely. And the fundoplication itself, it also, we make it anteriorly for the fundoplication. You might have seen the fundoplication, I mean the stitches on the right side of the patient. It also several variety of the technique that you might need to familiar with, and because when you do some technique, actually they have the some detail in that technique that you have to learn. Otherwise, you have seen from the video and you try to repeat, it might cause some difficulty for the patient.
Because now we have the HRM, so when some surgeon refer to us to do the manometry before do the hiatal hernia repair, and I found that I found the abnormal of the esophageal motility from the patient who have the hiatal hernia, and after we saw that for the Nissen fundoplication, we trying to refrain from that one and do the partial instead, because some patient will have some esophageal motility disorder together with the hiatal hernia, so something may happen. Thank you, Professor Suthep. And so we will move to another lecture from the Dr. Bandhuphat Chakrabandhu. He will give another topic is about the fundoplication, perfect Wrap-Nissen, Toupet, or Taylor approach from the Dr. Bandhuphat Chakrabandhu. He is the upper GI surgeon in the Chiang Mai University Hospital. He is graduate from the Tokyo University in Tokyo, and now he is the work at the assistant professor in Chiang Mai University. Please.
Okay, good morning again, ladies and gentlemen. Today I'm going to talk to you about the fundoplication. Topic is the perfect Wrap-Nissen Toupet. The topic is quite difficult because nobody perfect, right? That's our tele approach today. We're going to take a look into perfect wrap, which we are provided with the only two options today with the Nissen, Toupet. Indeed, there is also door fundoplication, which is rarely popular. Also, the historic Belzi Mark IV fundoplication, which we can use in the thoracic approach situation. Also, a simple heels repair and some other variation of fundoplication. Okay, but today we are going to just focus on these two variations, Nissen and the Toupet. Okay. I would like to give you an insight about the etiology a little bit because GERD, the main indication of the fundoplication, which it is resulted from a failure of the distal esophageal reflux barrier, which may result from the three factors I show here. First one is the TLESR or transient lower esophageal relaxation. This happens as the LES relax separately. So in this case, there's no initiation from swallow, which result of enlargement, GE junction enlargement, then increased reflux of gastric contents and gas. It's initiated randomly without your swallowing. The second one is what Prof just gave us the lecture is a hiatal hernia. This increased the degree of the reflux during the TLESR. The last one is the hypotensive LES, which is the main etiology in severe reflux patient. This in severe reflux patient, you might consider this problem rather than TLESR because if the LES pressure is lower than 10, reflux tend to occur really frequent. And if the LES pressure is less than 4 millimeter mercury, free reflux occur, especially when if the reflux happen every time patient lie down, you could consider that the patient might have the low LES pressure. So this is the summarize of the indication of the anti-reflux surgery. First is quite tricky. First one is the failure of the medication, which is a complicated situation because you know that the good response to the anti-acid medication is the good predictor of the good outcome of the anti-reflux surgery. However, still, subgroup of patients who have the objective proof of a pathologic reflux still get a good outcome from the from the fundoplication. This means that you have to choose your patient carefully if you decided to go to surgery with this indication. Second one is quite contrary. In the patient who is already successfully treated with the medication, is also a very good candidate for the surgery too, because you know that we made this publication, the surgery is better than medical treatment alone. The esophagus significantly exposed less acidic content, also increase LES pressure, increase patient satisfaction, and improve their quality of life. The third one is also when the patient presents with atypical symptoms such as asthma, hoarseness, cough, or chest pain, dental erosion, aspiration, and also you also need to do a good objective confirmation that the patient have a pathological reflux as well in this indication. Also, just as Professor Suthep and Professor Kanokkan already show us, indication for anti-reflux surgery is also an just adjunct procedure to be performed if the other disease needs to be taken care of. If the patient have achalasia, if your patient have a hiatal hernia, some patient have a gastric volvulus, the anti-reflux surgery is also indicated in this kind of situation. And also, if your patient have the complication of the GERD, you can see the picture here, you can see the nice Barrett esophagus, you'll see the GERD with the stricture. This also happens when patient have a severe reflux, and it's also indication of reflux surgery. This is the objective confirmation I'm talking about. First, you need the information about the reflux, which is the gold standard is the 24-hour ambulatory pH monitoring. This is very crucial, especially in a medical failure and atypical symptom patient, which I already mentioned. You also need an information what Professor Kanokkan just discussed about. You can about how good your movement of the esophagus. You need esophageal manometry, because this is also very crucial information. Whether procedure you decide to go on a partial or with a complete fundoplication, which is the issue I'm going to talk about later too. Also, an upper endoscopy. When patient have a Barrett or stricture, maybe the indication, but also you need to make sure that there's still no dysplasia or early cancer, which sometimes already happen when you detect the Barrett esophagus. So and also, in my opinion, when patient present with dysphagia, this is a very, very good point that you need to go in to prove that there is no cancer in the stomach too first. So this is my very first investigation you need to do. Sometimes in some dog surgeons prefer to have also a barium swallow, so you can predict, just as Professor Chainarong showed us, how predict how good it responds. You know the nature of disease and how the cause of disease was going. The perfect wrap. I'm going to talk about an overview a little bit about the perfect wrap. So after we know the insights about the disease, you know that first you need the perfect result. You have to choose a proper patient first. And so we already did the first half of the task to obtain the good result, that we know that who is the good candidate to go into surgery. Now to take a look to the detail of the procedure, the fundoplication, to the perfect one. There's two consideration that is the most surgeon concern. That first, we have the good objective result that we already the purpose give it as the purpose of the procedure. The perfect result is the patient is significantly free from the significant reflux in a long term. This is the first one. And also the counterpart of it, there's no dysphagia. Because if you wrap super tight, nothing can go up, but also nothing can go down too. Right, so you have to understand how the fundoplication works, because it is not only work from the pressure rising, it also works from the gastric movement too. I'm going to show the meta-analysis here first. There's no difference in post-op heartburn, post-op regurgitation, post-op Demister score, or post-op esophagitis when comparing the Nissen and the Toupet. Most of the major outcome is equal, right? However, if we are on the Wrap-Nissen part, LES pressure is higher in Nissen. This is normal because it's with wrap around and the pressure rising. If you put something just aside, it's not going to raise the pressure of the esophagus. And also, if we take a look here, for the dysphagia, you can guess, right? Toupet fundoplication is better, especially if we focus on a short-term outcome. if you follow up patient less than 3 years, LTF, lap Toupet better. If we follow up more than 3 years, the result become equal. This is also a very, very crucial result here. If patient have normal movement, lap Toupet perform better. If we perform Wrap-Nissen in normal esophageal movement versus and lap Toupet in abnormal movement, the result is still equal. This means that you need to choose lap Toupet in the abnormal movement patient. So the movement of esophagus, the lower esophagus, is very important in this case. We decide to go Toupet or Nissen. However, the result is a little bit discordant. If patient have abnormal esophageal motility and we do lap Nissen and lap Toupet, it's about equally. However, we still can see the trend here that the Demeter score, and Demeter score is the objective result which derived from the subjective result. We choose 3 parameters, combine it together to get the score. You can see that it a little bit favor a little bit, but it's not significant. It's favor Nissen. And also LES pressure, what I just mentioned, this is a significantly raised after Wrap-Nissen fundoplication. So if we focus on LES pressure, it's quite clear that the Nissen is better. In this slide, I show the motility in the subgroup comparing the Nissen and the Toupet. You can see here that most of them favor Toupet if you focus on the dysphagia, but only good motility group have the significant better result. And still, I want to emphasize on this result most because the abnormal movement is of esophagus who we did Toupet still on par with the normal motility Nissen. So you should keep this as one of your main consideration. I'm going to show the long-term result follow-up at the 10-year by Dr. Della-Magni. You can see here that it still performed better after free of significant reflux at 10 years. About 10%. The post-op dysphagia is concordant with the previous report that there's almost no dysphagia in Toupet and it's about 4% in Nissen fundoplication. This slide is very important. It's like my pearl of this presentation because you can get mostly good result from either Toupet or Nissen. However, the consideration and detail in doing each one perfectly is different. In this literature, it shows that the length of the wrap is important when performing a Toupet fundoplication. So we can see here the 1.5 per centimeter Toupet is worse than 3 centimeter Toupet. 3 centimeter Toupet proved to be a better choice to control reflux. You can see here 25% versus 5.4% treatment failure. So if you decide to go to Toupet, you need to have at least 3 centimeters of the length. However, the length of the wrap in a Nissen fundoplication is not really influence the reflux control. I think you hear before about a short floppy Nissen. This and in this literature it shows that 1.5 centimeter Nissen versus 3 centimeter Nissen, the treatment failure is not significantly different. So it is quite weird, but the result is very important. So you see here the last line, mild dysphagia rates was higher for the 3 centimeter wrap. It's 21.2% compared to 8.8% in the 1.5 centimeter wrap in the 1 year follow-up. So this information tell you that when you do Nissen, you might consider to choose a shorter Nissen, short and floppy Nissen instead of a long Nissen. So I will talk a little bit about each one indication. So Toupet is good fundoplication. It's very good. Some surgeons rely on the Toupet alone because some surgeons cannot comprehend with the patient if they present to them with the dysphagia, which is might caused by the procedure itself. So this is also one of the good option. And also you need laser fundal mobilization comparing to the Nissen technique, which you need to wrap it totally around. Some surgeons prefer using this technique in adjunct to hair myotomy, just as Professor Kanokkan said to us that it keeps both aids of myotomy separated from each other, so we like more confidence in the result of the myotomy. So it is also a good alternative approach. As I mentioned, if you have poor esophageal motility, you should go with the Toupet. But if you don't know it at all, because I believe that in some situation, or especially some of Eastern Asian country situation, sometimes our institute cannot investigate patient with the manometry. Sometimes we don't know, so it might safer. I can say it's safer to do the Toupet as your main fundoplication as your main, because sometimes we cannot get to the investigation. Surgical detail in a good fundoplication. First, Dr. Kanokkan already showed you that first, and also Professor Suthep, that the good crural dissection should be done cleanly. This is like the basic of all the upper GI surgeons and all of the MIS surgeons. And so if you dissect it cleanly, you can obtain the adequate abdominal length of the esophagus. Just as Professor Suthep mentioned that 2 to 5 centimeters at least you should obtain before you perform the next step of the operation. And always do crural closure to close the hiatus to minimize the chance of the migration of the fundoplication too. This is my short video. In Toupet, I cut the short gastric vessel too. Because comparing to DOR, this still need more amount of the tissue to go to be able to wrap posteriorly, and we put it behind. Thank you, Professor Pitisha, editing this for me. I always do a crural stitch before I pierce through the edge of the myotomy. If you do this in this just a GERD case, you should aim for about 90 degree anterior at the edge of each side in front of the esophagus. So you can see the fundus will lie about 200 degree posterior to the esophagus. We proceed to the next one, the Nissen fundoplication. It's still the best if you focus on how good you control the GERD. You can see that 90% at 10 years is nothing can beat it. However, as I mentioned earlier, in my opinion, sometimes you don't need to be 90%. You need 80% without GERD, without dysphagia. Sometimes that's better for some surgeons. It's also suitable with patient. You already confirm that you have good esophageal motility and aim to the best GERD control result. It requires more dissection and more technical to free the gastric fundus compared to the other technique. From where I learned, for last time I learned with Crow, for the esophageal stitch, he doesn't do that. I personally doesn't do the esophageal stitch too, because I believe that if you do not too tight Nissen, you should get a good result as well, and it should not migrate into the thorax, and it should not migrate onto the stomach too. First, I start with the same thing, crural dissection, and also the cutting the short gastric. This is our hiatal hernia case. So we divide the connection between the crus and the gastric, the mesogastric a little bit too, so to get the enough space to pass the fundus behind. You can see that the crus already approximate here, posterior, just only in posterior pass, just like Professor Suthep. Try to get a mobile fundus, and when you don't put in the pressure, it can relax freely at the posterior part of stomach. So it the indicator that you have quite enough the tissue relaxation here. I did a little bit different from Professor Suthep, because from what I believe that I learned from Crow and the literature, I did a very short one. You can see here I only performed 2 stitches instead of 3 stitches. And after you tie it, I try to check it again that is still a space behind. A space behind it, and it can move freely. So I put about 2 centimeters apart stitch, a very thin one. Then we complete the procedure. In the hiatal hernia case, I almost never put the med in if I can close the cura. What is the purpose of my technique? I try to preserve the overlying peritoneum that cover the crus. I found that it helps a lot to make the crus stronger when it's joined together, and it can hold stitch better. After I finish, I try to pull it down and pull it up, and if it can move freely, it's good. This is fundoplication for me. So this is my take-home message. Pre-op patient evaluation and patient selection is the crucial part, half of the task to do to success in the treatment. Nissen is slightly better in long-term reflux control. Toupet has lesser incidence of dysphagia, especially in early follow-up, so it's safer to do Toupet. in poor or unknown cerebral motility patient, nothing perfect. So I mean that you need to choose between two after you and your patient know all of the information. And also you need to get a very good technical in each one you perform. Longer Toupet is need to achieve a good outcome. Also a shorter Nissen is need to lesser incident of this figure. Thank you.
Thank you, Dr. Prathanvanich. He give us about the information for many fundoplication. But how do you select which type of the fundoplication which suitable for the patient? Please give us some recommendation.
This is better to address. This is my personal recommendation. For the Achalasia, I always 99% doing doors, because I believe that the fundus that you put as a cover on the myotomy, it helps to prevent the unintentional burn, or because I use focus on the harmonic square wave, sometimes it have a little small burn on the mucosa, which we don't really know how it would perform after the operation. We close the abdomen, we cannot know how what's going. So in my opinion, for the Achalasia, I do a door. For a patient with GERD, present to us with GERD, which focus on getting better quality of life. When patients come to us with GERD and they want the fundoplication, I perform Nissen, because this is the main objective of the patient. That they want to get better. So Nissen is like the best in the reflux control. If the patient come with the indication from just GERD itself, I do Nissen. And last, if patient come to us with the hiatal hernia, which is mostly the patient is an extremely old age in this kind of disease, and also the movement of esophagus is not really good. If you perform the manometry, you will find that the average DCI a little bit lower. It's maybe not abnormal, but it's lower than normal patient. If the patient is old and come with us for the indication of the hiatal hernia, I perform Toupet. This is my recommendation.
Could I ask Dr. Pornthep to share about your experience? How do you choose the fundoplication according to the patient?
Yeah, same thing for the hiatal hernia. Mostly I did Nissen fundoplication, but when you send the patient for investigation like a upper GI study, I almost always to ask radiologists to see any abnormal peristalsis or not, because for the real-time upper GI study, sometimes you can see abnormal peristalsis. That one I'm gonna send to manometry check up first. If some abnormal, that maybe need only partial fundoplication. And for Achalasia, if I can dissect nicely myotomy without any injury to the mucosa, I'm gonna do Toupet. But if concerned about the mucosal injury, I'm gonna do DOP fundoplication. Because Toupet can partial fundoplication and also can traction the myotomy to help.
Thank you very much for all speakers for today. Today we have many thing to discuss about the common upper GI disease, and today we will go to the cadaveric workshop in this afternoon. So you can do the fundoplication, you can do the Myotomy, and we have the teacher to guide you to do this one, and we are at the end of this conference, and in the morning session, I think this time we need to meet Dr. Professor Suthep Udomsawaengsup. He is our course director for today, and he will give us the closing remarks.
Thank you very much. Thank you, Kanokkan. Thank you, Bandhuphat. And also, thank you everyone. For those who join by Zoom or online, we wish that very soon you'll be joining us here at T-TEC and King Chulalongkorn Memorial Hospital. I hope that the academic knowledge and sharing here will give you a benefit of having a better and more practical point to your patient. Please stay safe, and we'll see you in person here in Bangkok very soon. Thank you very much. And for those who are sitting here joining us in place here, in the afternoon will be very much a platform that we're preparing for you. We will discuss about the how to perform the upper GI procedure, especially fundoplication and myotomy, which are very useful. And the soft cadaver will give you a very, very real platform that you will experience. And I hope that after having the experience in our workshop, you will be able to having the procedure for your patient. Thank you, and see you in the workshop.